So the prostate, so we're moving on from blood flow, we're moving on to just a organ that is responsible for a few things. We'll talk about in the next slide. One of the big things it's responsible for is making sure that it is a, just like a train, is making sure the right thing is going in the right hole, right tube, right? So when it's time for sperm, it opens up, the railways go to the sperm situation, right? And when it's time to pee, then the railways are going to shift over so that we can allow urine down out the urethra, right? So we're doing a 2-for-1 deal with the penis. Okay, so prostate issues. Well, this can get super swollen, right? The prostate gets super swollen, and it's going to start to pinch off the urine flow, is what they're going to complain of, right? And then they can get swollen because of extra tissue, like prostatic hypertrophy. Hypertrophy is excess tissue, right? So that's BPH, benign prostatic hyperplasia, right? And the other thing we're going to talk about is tumors, right? So tumors can grow, and of course, they can be, if they're stage 4 cancer, prostate cancer, it has metastasized, right? One of the places that it can metastasize to, right? Prostate is one of the B's, right? Prostate, it goes to the bones, right? So it can metastasize to the bone, right? So that's our deal. And one of the things we can do is we can palpate the prostate. The only way we can palpate the prostate is through the rectum. We can feel the back wall of the prostate. And the back wall is where, BPH, you can appreciate, is much, much bigger than it should be. But with cancers, they usually grow on the other side of the rectal wall, or the anterior prostate. So this is the rectum right here, and you put a little finger in there, right? Let's put a finger, right? There's a finger, right? You put a little finger in there, you're only palpate the back of the prostate, right? You can't really palpate the front of the prostate, where usually prostatic cancers develop, right? So back down here in the middle bottom, there's a big prostate. That's a BPH, a benign prostatic hyperplasia. We won't be talking about prostatitis. Prostatitis usually is from infections due to STIs usually, but that can happen. And that's, of course, to be a very, very tender prostate, and of course they're going to have some infectious symptoms. We're really going to be focusing on BPH versus prostate cancer. So you're making a little table, you want to differentiate the two. Like which one is, what are they caused by? Ironically, just like with chronic pancreatitis caused pancreatic cancer, peptic ulcer disease caused gastric cancer, colitis, ischemic colitis, and what else? Crohn's disease and ulcerative colitis put you at risk for colon cancer. Prostate and prostatitis don't cause prostate cancer. Prostate cancer is kind of independent of those, which is another unique cause of it, right? All right, so BPH will be first. All right, so an enlarged prostate, right, is BPH, so benign prostatic hyperplasia. And again, BPH does not cause what? Cancer, right? Or prostate cancer, I should say. And then, however, one can have both. It's like, oh, look, so there it is. It's because they had the other risk factors for prostate cancer, right? Which, ironically, is probably weight, right? And obesity and smoking, alcohol, those are all going to be contributing, right? So, just like testosterone decreases with age, and you get osteoporosis with age. With age, and ED you can get with age because of the testosterone situation. But with here, you have 90% of those over age 80 have a big prostate. It's in the cards, right? It's going to happen. All right, so 90% of those over age 80 get BPH, right? The prostate keeps growing from age 35. It's a normal part of aging. And it's kind of related to testosterone also, and we'll describe that. All right, so risk factors for this is aging, right? And peak testosterone is at age 25 to 30, and then 1% per year, it starts decreasing over time. And then your body's going to try to conserve testosterone. It actually stores it away as a more powerful testosterone, and it upregulates your tissue. So just in case, because testosterone is going away for the winter, it like hibernates, right? And like stuffs nuts in his mouth like squirrels, right? And it's going to you get a big prostate. All right, inflammation. So just like I said, inflammation, these things can cause prostate cancer, and these things also can cause an enlarged prostate, right? So diabetes, obesity, ASCVD, poor blood flow, which is diabetes, ASCVD also. And hypertension can cause damage to the prostate, and then it becomes more hyperplastic. It grows in more and more tissue, right? So what does the prostate do in the first place, right? What is the whole purpose of the prostate? We mentioned it's for a, it's like a railroad crossing. It's going to, what they call these little, the switch operators, right? It's going to make sure we have the right path, right? It's suck if we have, you have the sperm train coming up, right, from the testes, and then all of a sudden the track is on the wrong area, right? That's not going to be great, right? So we want to make sure that the prostate is responsible for making sure that is good. And also, as the sperm comes, literally, it comes through this tract here. It's going to, it gets to-go snacks, right? And it gets extra lubricant on the way up, right? So there's little vesicles and other things that it squeezes into the this sperm train that's coming. And it's going to add little to-go snacks there, little string cheese to go, right? And it's going to also douse it in fluid, right? In what's called semen, right? It's a carrier fluid, and it actually has a whole bunch of other nutrients for the sperm as well. It has like prostaglandins, ironically, and other things to start contracting muscles, right? And the muscles it's contracting is, yes, the spermatic pathway, the urethra and such, so that the sperm can make it out of the penis, but also it contracts the vaginal muscles, right? If the purpose is for intercourse, or vaginal, because there's male-male intercourse too, but I guess it would contract that too. I don't know. So it's going to contract and push the sperm along up to its, the normal path all the way to the ovaries, right? Or the implanted ovum. So that's kind of what the fluid can do as well. It provides nutrients for the whole pathway. It's like going to Mordor. They need a lot of string cheese, and they need a lot of lubricant, a lot of members of their party to make their way all the way up. It's an incredible journey, right? For a sperm, for that matter. Okay. So again, it's a mechanical switch, right? It's also a semen kitchen, right? And you can buy this book on Amazon. I don't trust it, but it's 69 different recipes to make with semen. It's like I don't trust some people, some hosts, but that is a legitimate thing because it does have nutrition in it, but you can't get enough protein. It has a lot of like zinc, it has salt as well, but there's a lot of nutrition facts. There's a lot of things they did in history to try to like improve their complexion, and it's a whole thing. Either way, it turns off the urethra and turns on the seminal vesicles. So semen being semen, right? So this is the back of the bladder. So we're looking at this part back here, right? And that produces all the semen, all the fluids, right? So 10% of semen is sperm, right? Like a whole not buttload. That's the wrong word to say. The whole the whole mess of, what's another bad word? What's another good word I should say? A whole quantity of semen that's only 10% of it is actual sperm. The other 65% is the seminal fluid, which has bicarbonate and prostaglandins to promote, like we said, contractility. Also, the vaginal wall, the vaginal space is acidic, right? So we want to make it basic so that the sperm can actually survive. And again, the sperm make their way where they come from in the first place. It's only 10%, but they're all made down here, right, in the testes. And they differentiate from a germ cell, and they actually go through meiosis, right? Everything in the body goes through mitosis, right? Mitosis is where you make two exact copies. Meiosis, you're only making one. You're splitting your cells. You end up with half the chromosomes because the other half is going to be the ovum, so you make an offspring, right? So you have all these sperm, and how much sperm are you making? You're making about 1,500 every second, right? Well, some of us are, right? So 1,500 every second are being produced, and these guys are going to be ready to go, and they're going to go on a little journey. They're going to go all the way back here and out, right? They go on a huge loop-de-loop, and right at the end of the first loop, that's where they get all the seminal fluids, right? And then it give a little to-go snacks, like we mentioned, and then the prostatic fluid is going to be the prostate itself will squeeze out some fluid, right? So we have the seminal vesicles right next to the vas deferens, but also the prostate itself down here will also make some seminal fluid, other about 25-30%. Okay, and again, more nutrients, right? Also, prostate-specific antigen gets released, secreted there, and PSA is something we can measure to see if there's too much PSA, there's probably too much prostate, right? Right, and then just FYI, also the other reason how sperm or semen gets out, yes, the vas deferens contracts with prostaglandin activity, but also we have a little bulbasaur muscle down here at the base of the penis that's going to actually eject the semen to get to its destination, right? And also our prostate secretes the precum, which is going to be still has some potency to it, right? There's all kinds of myths out there. Oh, you got, at the end, that's all that counts. No, it's the whole deal, the whole shebang, right? All right, so prostate. All right, will grow in response to low testosterone. So your testosterone decreases with age. Therefore, you're going to have a bigger prostate, right? And then decreased blood flow, like diabetes, hypertension. We have increased S-des activity, that's vasoconstriction, so it's decreased flow, right? And inflammation, like we mentioned, right? And all of these are, if you have a swollen prostate, yes, you're going to have inadequate semen flow, but they're going to be complaining of the prostate squishing the urethra here, right? So if all this urine that's backed up, right? All this urine's backed up there and it's trying to get through, but the prostate is so swollen it can swell shut the urethral tract. Right, tract even, all right? And that area is actually called the transitional zone, which I highlighted here. So transitional zone is the area that's just around the urethra, and that's the part that actually gets hyperplastic. So that's not very helpful, but that's the area that will increase in size and swell shut the urethra, okay? Yes?
Are there testosterone supplements that are safe to take? Or?
So, yeah, people get testosterone shots, yeah. Mm-hmm. Yeah, testosterone doesn't cause like clotting like estrogen does. Estrogen, people think, well, if they have menopause, let's just replace the estrogen. Well, there's too much risk of clots in that case. Okay, so yeah, so these cells right here, the lumen of the urethra, it's going to they get hyperplastic and they can swell shut the prostate, right? And also these guys kind of store testosterone, and that storage of testosterone actually makes the cells hyperplastic as well. So we try to shut that off. We try to stop the production of those long-term testosterones, which we'll talk about next. Okay, so testosterone. Your testosterone is low, right? It's decreasing with age, right? It can be due to hypogonadism or endocrine issues to begin with, but what do androgens do? They are going to get released with the stimulation of their precursors. Their precursors being gonadotropins or FSH, LH. You know, it's also used with menstruation, but it's also the guy. It's used to make testosterone, but also women. Not only is it for the menstrual cycle, but it's also for testosterone production, because not all testosterone is made in the testes, right? Another portion of it is made where? Not the pituitary. The pituitary stimulates the release of it. The adrenal glands. I thought I had a picture here, by the way. So it's made in the adrenal glands as well. The adrenal glands make estrogen and testosterone, and then women make more estrogen in the ovaries, and men make more testosterone in the testes, right? So when you release these stimulating factors, you get more testosterone, you get more estrogen, and the testosterone is going to travel through the bloodstream, right? So, and through the bloodstream, and then it got cut off here, but it travels through the bloodstream, and then it's going to deposit itself in the target tissues. Skeletal muscle to make the muscle grow, and the testes will make the testes produce more stuff. And then in the prostate, so the prostate cells here, it gets converted into, over here, into DHT, right? DHT or dihydrotestosterone. Right, as I said that right, but yeah, dihydrotestosterone, DHT, as gets converted by this enzyme. And the reason why I bring this up is because this enzyme is someone we're going to inhibit when we want to fix BPH, right? So we want to stop this extra production of this DHT, which is 10 times more potent than testosterone. Okay, so testosterone will be converted for later, right? And when you have with age, when you have decreased testosterone, your body is going to try to conserve it by converting it into this long-term substance. But little did we know that also makes the prostate get bigger and bigger. Okay, so with 5-alpha reductase activities, so we want to stop that when we want to prevent or manage BPH, right? So DHT will increase growth factors. All these little growth factors will make the lumen grow, and also the lumen's growing here, right? And also the cells around it will grow more as well and pinch off the urethral flow, right? So what else can I say about that? So yeah, so androgens also bind to androgen receptors directly. So you can see DHT right here, right? DHT is going to bind to androgen receptor, and testosterone itself is going to bind to the androgen receptor, and that will cause the cell to overgrow, right? So that's the idea with our testosterone and androgen receptors. And we bring this up because we talk about prostate cancer. there's certain prostate cancers that are related to excess hormones. So we got to shut off the hormones. So we're going to give medications that are going to shut this down, right? And also, I think I mentioned here, testosterone is made by this enzyme, and that's why in prostate cancer we shut down that enzyme, and therefore we're going to have a reduction in testosterone and a reduction in the growth factor for that prostate cancer, for instance. But for BPH, it's really the DHT that's a problem, causing overgrowth of those prostatic cells. Okay. What else? So periurethral hypertrophy. So we get that extra growth of cells around the urethra, and it grows and grows and grows, and it's going to cause pinching off of the urethra, causing urinary symptoms. Okay. So what else? The SNS activity we mentioned. So increased SNS activity is going to overgrow the prostate. Right? There's actually alpha-1 receptors all throughout the prostate. So if you have SNS activity, it binds to all adrenergic, not androgen, but adrenergic receptors throughout the body. And a lot of those receptors are in the prostate, so it's going to cause it to overgrow. Right? So the reason we bring that up is because we have alpha-1 blockers. And the alpha-1 blockers are going to help with prostate overgrowth and also help with urinary symptoms so they can actually pee, right? So to pee, right, when you're running with a bear, you might pee yourself first. But if you're running with a bear, the priority is not to pee, right? Your priority is to, not to rest and digest and pee, but to be flight or fight, right? So when you have alpha-1 activity or you have SNS activity, you pinch off the muscle there and you do not pee, right? And then to relax it, you have to release acetylcholine, right, which is from the parasympathetic nervous system to allow the relaxation of the bladder and relaxation of the urethra to then allow us to micturate, right? So that's going to allow us to finish the process, right? So alpha-1 antagonists, they're going to stop the alpha-1 receptors. They're going to inhibit those alpha-1 receptors there and allow you to pee, right? People have to improve the flow, right? What's it called? Flow Max, right, is the brand name for it. So Flow Max is going to maximize the flow by inhibiting these alpha-1 receptors, allowing us to pee, okay, with patients with BPH. All right, so decreased blood flow we mentioned, right, can increase hypertrophy, and then chronic inflammation. All these things are contributing to BPH, right? And we highlight in green some of the enzymes that get inhibited when we have when we want to introduce medications. All right, so symptoms. So we can separate the symptoms into two primary mnemonics, right? So we have wise and funny. So lower urinary tract symptoms, all right, they're going to have symptoms of a swollen prostate and therefore urine can't get out, right? So they're going to have a weak stream because the urine can't get out. They're going to have intermittent stream because the urine can't get out. They're going to have straining to initiate the stream because the urine can't get out. They're going to have emptying problems. They might have dribbling because the prostate's overactive, is not working great, right? And also they can't get the urine out to begin with and then the urine's going to back up, and then it's going to like spasm and then squeeze out a little bit of drops unintentionally. And that's overflow incontinence, where we're filling up with fluid here, right? I think this is tenesmus, but the fluid is overflowing, and then we're going to pee out a little bit. We're going to dribble a little bit. Okay, so those are wise symptoms, signs of a swollen prostate, right? And then if they have bladder obstruction, you can also say it's a bladder storage problem. We have excess urine in the bladder. It can say funny. So frequency, they're always going to the bathroom. They have urgency, so their bladder's full, and they're like, oh, I got to go. Because when your bladder gets full, there's little receptors there that will tell you when it's like half full, so you should go pee. Go find a rest stop. Let's do this, right? But then when they can't even initiate the stream or get the urine out, they're going to have urgency. They're going to have urgency symptoms all the time. That will carry over into the nighttime, and they'll get nocturia, where they're waking at night to pee. So is that a safety concern? Yeah, right? And then incontinence. So they have incontinence because of that urge incontinence, right? They have bedwetting. All right, so you can score this on this little international score. It's an official way to assess how bad someone's BPH is. Okay, so we mentioned about 90% of those over age 80 will get BPH, and it's all due to a hormone situation. They have decreased flow to their prostate. They might have inflammation from chronic obesity, right? And all these things are going to cause voiding symptoms. Okay, and then on the next slide, I think we talk about the complications that can happen if urine. So what? Urine can't get out. They're going to have a miserable life, but nothing else bad will happen, right? So in red, there are some bad things. So bad things being that the bladder is, the urine is sterile, but the tube going out is not, right? The tube going out you can have an ascending infection that can make its way up through the prostate and into the bladder, causing a cystitis or a UTI, right? And it can make its way further to get to where and cause what kind of infection? Causing pyelonephritis all the way up to the kidneys, right? So you can see here on the left is a normal kidney, a normal bladder, and on the right here we got a swollen bladder because we can't get the urine out, and then the urine kind of makes its way up, and it pops open the ureters, and it goes all the way up into the kidney, and now we have, if that's infectious, now we have a kidney infection as well. That's always the worst case scenario with a UTI. Okay. So assessing for a UTI is important, right? And how do you assess if someone has a UTI? Diagnostically, they could smell and such, but really definitively is looking at the leukocyte esterase. Do they have nitrates that are positive? Some bacteria cause hematuria, but creatinine could be, if you have kidney involvement, the creatinine will go up, and that's a sign of bladder outlet obstruction. There's not ability to get the urine out, and that can lead to acute urinary retention and UTI symptoms. So we got cystitis, we got maybe some hematuria, bladder stones, because the super concentration of urine is going to have nothing else to do, and then you can have all kinds of extra opportunities to make stones, right? And then hydronephrosis. So we got stones up in the kidneys, but also, we got nephrolithiasis, but we got fluid up in the kidneys, right? And that's going to swell the kidneys and kind of shut down the kidneys. So it's not good. Okay. Other things you can assess for a high prostate besides the complications, or a big prostate, is a digital rectal exam. So DRE, right? So you provide a gloved finger, right? And you use lubricant, and you're going to assess the prostate. And it should be about as big as your thenar eminence. And where's your thenar eminence at? It's like my hips are somewhere, right? No, it's the thenar eminence is on your hand right here, right? So the thenar eminence should be about 2 finger breadths wide. That's how big a prostate is, right? And that's not what a prostate feels like. A prostate feels like an eraser, right? And if it has bumps on it, that's not good. It should be a smooth eraser, right? So it should be smooth. It should not be big. If it's bigger than that, so here's 2 finger breadths about. If it's bigger than that, then you're going to really be able to tell. If you start having bumps there, that's not good. That is a sign of cancer, right? It should be smooth and big. That is BPH, right? If it's bumpy at all, that is a BPH. Sorry, is that bumpy at all? That is a cancer of some sort. Okay. And then the other piece is if it's tender, that is prostatitis, which we're not talking about. Okay. All right. So then prostate cancer. Since you're up there, right? Do 2 for 1. All right. Assess if they have prostate cancer, right? And then the other thing you can assess for to see if someone has extra prostate tissue or overgrowth of prostate tissue is a PSA, right? A prostate-specific antigen. So PSA measures the amount of this chemical being secreted by those cells, right? And those cells get secreted by those little stromal cells around the ureter. Yes?
Do you do this at the same time as a colonoscopy or something like that?
As a colonoscopy? That'd be, it's like, I would advertise that. These guys are up there. You can touch as much as you want, right? Just assess my prostate. That'd be cool. Yeah. Get a 2 for 1 is a good idea. Actually, I never thought of that. All right, we'll market it. It's a BOGO, right? Colonoscopy and DRE. Yeah, but they'll bill you twice. They will. All right. Anyways, we've got PSAs. If they'll be elevated when you have overgrowth of tissue, right? The magic number is usually 4-ish, right? 4 to 10 is a sign that there might be something prostate going on, but it's unreliable. It's not a great test to be done. When it is 4 to 10, you can differentiate if it's cancerous or BPH. And it's on how much is bound to the PSA. So the PSA gets released, and when you have BPH, it's not bound to this other protein. But when you have cancer, it's all bound to the protein. So you can measure how much is bound, right? So if less than 25%, is free, meaning that 75% is bound, right? That is a sign of cancer. And this is only when the PSA is 4 to 10. Okay, but normally the PSA just gets squirted out and it's just there. It's free, right? It's not bound to anything. So that's a sign of BPH, whereas the other one is cancer. Okay, so what else on treatment? So again, PSA is not super reliable, but they can do a, I think we have the next slide, the MRI, but the things we can do are watchful waiting. So if they see a big prostate or they see even prostate cancer, they have an informed decision. Right? If they're like 85 years old, going through invasive surgery to fix this might not be the best option, right? So active surveillance, all right? So with minimal symptoms, they don't have all, like on that previous slide, we have all the whole scale, right? We can objectively say you're a 10 on the scale. Whereas if they go up to a 15, it's like, well, now I should probably start taking medications. I should probably maybe get an intervention or two to fix this, right? Because with all the interventions, like surgical interventions, they're going to usually cause impotence and erectile dysfunction. So it really would want to monitor it, right? Because this isn't life-threatening unless we have what? These red things here. We start getting symptoms of urinary retention. Okay. But in the meantime, while we're waiting, and also it's probably a good tip for someone with BPH anyways, is to avoid the urgency symptoms, avoid the urge to pee by, not drinking so much at night, not like ETH, but drinking water at night. Avoid caffeine, avoid over-the-counter meds that might make it difficult to pee, right? And we mentioned that acetylcholine is great for relaxing the urethra and allowing you to pee, so giving anti-acetylcholine meds would not be great, right? It's going to stop the intended activity, right? So what's anticholinergic? Well, yes, atropine is, but that's not something someone gets at home, oh, heart rate's low, atropine, right? They're going to, something that's like, make you say like a Coltley has anticholinergic properties are like histamine, right? So your histamine drugs that are for like Benadryl and such, right? Diphenhydramine, that also has anticholinergic properties. Okay. What else? So if symptoms interfere with life functions, then we can start introducing these medication therapies. So the 5-alpha reductase inhibitors, right? So that's going to stop the production of DHT, which can cause extra growth of tissue. And we got alpha-1 blockers because the SNS is what's causing, yes, the overgrowth, but also the symptoms, right? And then surgical therapy if they start getting a lot of complications, right? So that's the idea behind this PSA, DRE. And also the DRE, you want to make sure that you are, yes, applying a gloved finger, but also you're, doing all the steps to make sure they are comfortable as well. This patient has a horrifying disability. They don't have an upper torso. Recommend some office music at this point. Males, okay. Mm-hmm.
We were shown actual vaginas, I think.
You're missing out?
Yeah, I did
If you could just squeeze my finger now, please.
All right, checking the ringtone at this point to squeeze the finger.
Okay.
So for these prostate exams for like doctors and NP students, med students, they have actors that volunteer for this. It's like, oh, no, a little more to the left, more to the right, a little deeper, you'll feel it, right? I got a BPH, you got to check me out. It's a crazy thing. You can pay like $1,000 for the gig. It's a crazy thing. If you're short on money, right, it pays more than sperm banking. All right, pharmacological treatment. So how do you fix BPH, or how do we reduce the symptoms at least, right? Because our goal is to improve the symptoms, right? It's going to decrease BPH progression by about 70% or so. So it's not going to like stop it in its tracks, but it's definitely going to help with the symptoms, right? And it works about half the time, which is pretty good. So 5 alpha reductase inhibitors. So these are going to stop the conversion of testosterone to DHT, and DHT was the problem that's causing extra growth in those the transitional zone around the urethra, right? And DHT reduces apoptosis because we want the prostate to function for a long time, so we kind of store it for later. So we want to stop that from happening and actually promote apoptosis and promote the stopping of DHT, right, production. The nice thing is testosterone and glucocorticoids and mineralocorticoids are all steroids, right? Those are all things that you have in your body that are steroids. Your adrenal cortex is your place in your body that you release steroid hormones from, right? Hormones come in 2 flavors. They come in protein flavor and steroid flavor, right? And these ones just happen to be steroid flavors. The nice thing is that this is stopping testosterone steroid production, so it kind of ends in steroid, right? So steroid, right? So finasteride, dutasteride, these guys are stopping steroid conversion, right? It takes about 3 to 6 months to have any kind of effect. So they come back to the clinic and they're like, oh, I still got symptoms. So it'll come back in 6 months, right? Unless you have symptoms of what? UTI, right? Anyways, so we have, you can also help with baldness. Finasteride helps with baldness. The, what's it called? Not Just for Men, what's the other one? Just for Men is the, Rogaine, right? Rogaine is the current one, keeps, right? So that's just finasteride, right? Also it has minoxidil as well. They sell both. Minoxidil will vasodilate and provide more blood flow to grow hair, and this will promote testosterone production, or sorry, stop the breakdown of testosterone. So you have more testosterone available to have hair, right? And it takes about 6 months, so you're locked in for 6 months. All right. So side effects though, breast enlargement, because yes, it's not really easy to figure out why that happens. All right. We have decreased libido because we're not having, we're not making as much DHT, and DHT is like 10 times more powerful than testosterone, right? It also lowers PSA by about 50%, and that's not great because it can hide yourself from cancers, right? It's like, oh, your PSA is not 4 to 10, it's 2, you're fine. It's like, yeah, but I might have prostate cancer or BPH, right? All right, so alpha adrenergic blockers. So these are blocking alpha-1. Remember, we have alpha-1 receptors throughout the prostate here, so we're going to stop that. Right, alpha-1 receptors, if you block it, you are going to flow to the max, right? You're going to use tamsulosin, right? Is going to inhibit, right, the SNS, right? So it's S inhibition, right? That's the best I can do, right? So SYN is inhibiting, right, the SNS, and then ZYN is inhibiting the SNS, but a little more broad strokes, right? So it's non-specific. So it's really going to affect your BP when you take one of these ones that end in ZIN. Right? So they are non-specific when they end in Z or have Z in the suffix, whereas SYN is very, very specific. It's going to directly inhibit that alpha-1 receptor just on the prostate, because there are different flavors of alpha-1 receptors. There's like 4 flavors on throughout the whole male GU, and this one is super specific. Our alpha-1 blockers that are end in SYN. Right? This takes a little less time, about 2 to 8 weeks, but it does improve symptoms, but our side effects will be vasodilation, especially our ones that end in ZIN, right? So, or Zosyn at least. Okay, so vasodilation, kind of the same thing with sildenafil. You get headache, you get congestion, you're going to get postural hypotension. That should not happen with sildenafil, but this one is directly going to block the alpha-1 receptors, so it's a little more broad strokes, right? So it's going to cause blood pressure to be low, so that what are we going to educate them to? To rise slowly, make sure they're intaking fluids, make sure they are not intaking fluids at night, but they are at risk for low blood pressure and orthostatic hypotension. Okay, so also you're blocking the SNS, and the SNS is responsible for shooting, right? So they're going to have retrograde ejaculation, or it's not going to shoot great, right? And then what else? So if you have an overactive bladder, we can use muscarinic antagonist. Muscarinic is a fancy word for acetylcholine. All right, so it's blocking these should be agonists, overactive. Sorry, I'm thinking of if the bladder's like spasming, right? We can stop the spasming of the bladder walls. Okay. So what else? So that's the idea here. So we're going to stop the alpha-1 receptors. We can stop the acetylcholine from overacting the bladder. You're like, well, that might lead to more symptoms here. Like, well, in the end, it kind of evens out. All right, so surgical management. Yes?
So would the alpha adrenergic blockers and the 5-alpha reductase inhibitors be given together? Since
You can give both, yes.
okay.
Yeah. Yeah, they usually are going to give both, and because it's going to take a while for the effects to take effect.
Okay.
Yes. All right, so BPH surgical management. When you tried the medications, you tried the non-pharmacological interventions, and then we need to do surgery, right? The definitive way to fix this is to take out to scoop out the prostate. So literally right here, it's literally just a scoopage procedure. They go in with a gentle device that's made of hard steel, right? And they go in there to the prostate and they literally just scoop out the prostate, right? It's a transurethral resection of the prostate. By resection is like in quotes, right? Because they're literally like, they're like harvesting, or like, what's the word? Like digging, right? They're digging and they're scooping out the prostate and they're making a space. Like, can you pee now? Right? So it's gonna make it much easier to pee, yes, and the recovery is pretty harsh as well. These guys are gonna come out with a Foley catheter. That's going to be a 3-way Foley catheter. 3-way being 1 lumen for pee, 1 lumen for the balloon, right, which we're used to. So we usually have 2 lumen catheters. The 3rd lumen is for irrigant, right? The irrigant is going into the bladder, and then it goes in the bladder and it comes out as pee, right? So a good picture is not here, unfortunately, but this is going to go in, and then out is going to come your urine, right? And post-operatively, the urine is going to be bloody, right? So usually if someone has bloody urine, we don't want it to clot off, and therefore they can now get urinary retention, right? So these patients guaranteed to have blood because they just literally scooped out the prostate. There was no like anesthetic given or anything. They just went to town and started scooping away, right? So these guys need a continuous bladder irrigation, a CBI, that goes through this 3-way Foley catheter, right? So the CBI is there to irrigate the Foley so we don't clot off that urethra, right? And then we have to go back to try to fix it, and that's not easy. Okay, so CBI management, like how do you manage a CBI? Because it's all you, right? Because the surgeon's not going to be there. It's like, oh, it's how much came out? I mean, it's your job to track the I's and O's, right? So remember, one goes in and one comes out, right? So whatever goes in, you have to keep track of. That's an intake, and whatever comes out is an outtake, right? So and that outtake's going to be a lot because you're probably putting in like a liter in 2 hours, and then what come out is like 1.2 liters. So how much did the patient actually pee? No. Well, they actually peed 1.2 liters, but how much did they actually micturate, I should say? 200 mLs, right? So you gave, did I say that right? We gave 1 liter, right? And they peed out 1.2 liters, right? This is only going into the bladder and coming right back out, right? In the course of 2 hours, right? So what's their actual output is 200 mLs, right? They're the balance, I should say. Okay, so intake is what goes in with our irrigant, right? It's usually like normal saline. It comes like a 3-liter bag. It's huge, right? And it just hangs in the IV pool there, and we irrigate the patient with this fluid here, right? It goes in, and it circulates right there, and then it comes out like pink lemonade, right, into the bladder. Okay, so it's our job to monitor, and you want to have pink lemonade come out. You don't want it to be bloodier than pink lemonade, right? So that's good, right? There's color charts and such, but really pink is what you want. You don't want it to be like super clear. Then you got to tone down the irrigant, right? It's all on us to adjust it, right? There's a little roller clamp on it. There's no IV pump. There's no Laris pump for CBIs, but it's a little roller clamp. And if it's all the way closed, you're not getting any irrigant, right? And you might be at that point where they're not bleeding anymore and they don't need irrigant. But right after surgery, you're going to need some flow, like halfway clamped, and it's kind of dripping, right? You can see it drip, and then it's going to irrigate, and you're going to monitor the output. Does that make sense in how CBIs work? Okay, and they're going to have clots and all kinds of fun stuff the first 24 hours. Okay, so a TURP, a transurethral resection of the prostate is what we're talking about, and that's what they do. It takes about 3 days of recovery. It's very, very involved. Okay, and the Foley catheter is going to stay in place while we irrigate with what's called CBI. All right, there's laser surgery like we can do. It's a little more refined compared to just scooping out the prostate, but we're still using lasers to eliminate the prostate overproduction or the prostate tissue that's hypertrophied and gotten out of control. All right, and then either way with the TURP or lasers, you can see this is what's left of the prostate. It's been hollowed out, right, so that we can now hopefully not have urinary symptoms anymore. Okay, so the other piece is open prostatectomy, and this is pretty, pretty barbaric. It's just where you actually just take out the prostate. You go in there and just take it all out, right? And now you took out the whole deal, right? They're guaranteed to be impotent at that point, right? With a prostatectomy, with a TURP, they're probably going to have some erectile dysfunction, but they still can shoot a little bit. They might shoot back into their bladder because the semen gets to this point, like, whoa, this is nice. Where am I at? Echo. And then they're going to, then they might have some problems with or insemination for that matter. Okay, so open prostatectomy is usually used with advanced BPH, but with prostate cancer. We'll come back to prostatectomy. Okay, guaranteed to have these problems. All right, so then minimally invasive. This is like if they're not a candidate for this huge operation, right? They're older, they have heart disease, they're not going to be tolerating this procedure. This is where we're going to do other little minimally invasive operations where they can go in there and just make tiny little incisions, 2 little incisions for the tip, right? With the it's only 2 little incisions instead of like scooping out the whole deal. They're just making little incisions there to hopefully stop the overproduction of tissue, right? And thermoablative, they're going to cook it. They're going to destroy those cells that are overproducing, and they're going to try to stop this whole overproduction with this intervention where they go in there and they either put needles in there or they are going to use lasers or microwaves to stop the overproduction of those cells. And then they got more ideas. We can use water, and we'll make it hot water though, and we're going to cook out the inside of the prostate. Okay. There's some options to stent it, to put little things in there, but the prostate's going to keep growing and growing and growing and kind of squeeze it shut. It's not going to really last that long. Okay. So here's examples of what to do with the TURP. We kind of mentioned all these things, right? So we want to make sure that we are assuming that making sure we're monitoring the urine to be how clear, or what characteristic? To be like pink lemonade, right? It should not be darker than that. Let's see.
This is one of the biggest design flaws of the human body and probably one of the worst organs. 0 out of 10 meet the prostate. Now if you're a man of the age of 50, 50% of you will have an enlarged prostate, and if you're lucky enough to live to the age of 80, 90% of you will have an enlarged prostate. These kind of prostates can compress your pee pipe, the urethra, so you can't pee properly, you get bladder infections, kidney stones. It's just a mess. But there is a simple solution. You can put a cystoscope inside and you can pass a laser in, and you can use that laser to fry the living hell out of the prostate. By doing this, you create more space around the urethra so you can actually pee properly, and yes, it feels good.